Hello, I'm Dr. Ken Edwards. I'm a local orthopedic surgeon here in Southwest Michigan and medical director of surgical services at Spectrum Health Lakeland. Thank you for joining me today. While we're waiting for some people to log on, let me tell you a little bit about myself. I've been at Lakeland for over 28 years, and I grew up in New York, went to college in Massachusetts and medical school in Syracuse, and after graduating from medical school, I did my internship at Portsmouth Naval Hospital and residency at the National Naval Medical Center at Bethesda, Maryland. Had the privilege of serving in the Navy for 9 years, and in that time had many adventures in the Navy that perhaps we can talk about. After leaving the Navy, I came to Lakeland. I've been in practice here for 28 years and have loved every opportunity that I've had at Lakeland. Now, to get started, let's watch a brief video about today's topic. So today we're going to talk about total knee replacements, new techniques and best practices. Now, a couple of disclosures. I'm the medical director of surgical services at Lakeland Spectrum. I serve on several boards for Lakeland. I'm also on the board of the Berrien County Health Department. But most importantly, I have no industry financial relationships that would serve as a conflict in this presentation. So the scope of the problem is pretty broad. We know that a lot of people in the United States have some form of arthritis. And if you look at this chart, you can see the growth of arthritis when we compare arthritis figures from 1995 to 2020. And a lot of things are driving increased arthritis. Well, number one, we're living a lot longer. If we look at that life expectancy graph, if we note that a third of people over the age of 50 are going to live to be about 100, there are going to be a lot of people that get older, and as you get older, a lot of people develop arthritic conditions. So if we look at total knees specifically, we can see some very interesting statistics. For example, about 4.5 million Americans have had total knees. Most of them are women. There's been a tremendous increase in incidence since the mid-90s. It's the fourth highest reason for a hospital stay, and very importantly, the annual costs are over $7 billion. And if we look at this graph, we can see the trend line. The lower graph is 1990, around the time I started practice here, and you can see the growth in total knee and total hip replacements. And if we look, when you do total knees and you do total hips, not all of them are going to last forever. And when they don't last, we have to do surgery they call revision surgery. And you can see, predictably, that the more total knees you do, the more total revisions you're going to do. The more total hips you do, the more revisions you're going to require. So when we look at treatment options for knee arthritis, I'd like to talk about the conservative and then the surgical approaches. If we look at the left x-ray, you can see a normal knee x-ray. And what you can see is there's abundant amount of space on the two sides. If you look at the right knee x-ray, you can see that there's really no space between the bones. And very simply, arthritis is a loss of cartilage over bone, so bone rubs on bone. And you can see that depicted in the right slide. So when we first see a patient who comes to our office and they're complaining of pain in the knee, we talk about the conservative management of it. And we can do that through diet and exercise. I get many patients that come into the office and are almost guilty because they're overweight and they think that their obesity has caused them to develop arthritis. And quite honestly, that's not true. Weight does not cause arthritis. Weight can make you more symptomatic. And so one of the things that we tell people is if you lose a little weight, you may lose some of your symptoms of your arthritis. There are medications that we can give people for arthritis. Most of them are called non-steroidal anti-inflammatories, and they include things that you're familiar with: Aleve, Advil, Mobic, diclofenac, etc. Physical therapy has a place in non-operative treatment of arthritis, particularly for strengthening the muscles around the knee and also reducing pain and improving range of motion. In some cases, we will recommend arthroscopy. Now, arthroscopy is a scope of the knee, and we do arthroscopy in patients with arthritis if they're having locking of the knee, and what that means is you can't fully straighten or bend your knee because something's stuck. Most commonly, you'll see us recommend injections as an initial treatment for arthritis of the knee. Simple to give, almost painless, and really give good temporary pain relief. Now, activity modification at the bottom of this slide is very important. And what I tell patients with knee arthritis is that lunging and squatting activities tend to aggravate pain. Excessive stair climbing tends to aggravate pain. And again, it doesn't make your arthritis worse, but it'll make it more symptomatic. Now, if we're unsuccessful with the conservative treatment options that I just outlined, then we start talking about joint replacement. And this afternoon and this evening, we're going to be talking about partial and total joint replacement. So let's talk a little bit about injections. There are basically 4 things you can inject in a knee: cortisone, hyaluronic acid. These are the gel injections that you hear about. Plasma, platelet-rich plasma, and stem cell treatments. So cortisone is extremely effective. It's a very strong local anti-inflammatory. It's very inexpensive. Most patients see that they have relief in about 2 to 5 days. Their duration of relief can be variable. I always tell patients anywhere from 2 weeks to 2 years because that's what I've seen. And generally with cortisone, we want to limit the injections to 2 to 3 in a lifetime. We try never to inject more frequently than every 6 months because cortisone can actually break down cartilage and can actually accelerate arthritis if it's given too frequently. Hyaluronic acid derivatives, or the gel injections, represent a fluid that's a normal component of joint fluid. It adds to joint lubrication and load transmission. Pretty expensive. And the FDA has really only validated its use on 1 or 2 cycles. And there's a lot of literature now that's talking about whether or not these are very effective or not. Stem cell treatments have become very popular, especially if you read newspapers in major cities like Chicago, New York, Los Angeles. And I think the prevailing concern is this really a good treatment or is it a hoax? And it's not FDA approved for arthritis. And interestingly enough, in an article in the New England Journal of Medicine, the FDA officials warned that there's a real lack of good evidence for this unapproved use of these treatments, and they considered it worrisome. So I think most orthopedic surgeons are quite skeptical of this kind of treatment. It's very expensive, it's cash only, and there is no good evidence to justify its use. So let's move on to why we're here today, and that's really to talk about knee replacement. And how do we go from the slide on the left that demonstrates a cartoon of osteoarthritis to the slide on the right, which represents a total knee arthroplasty. So exactly what is a knee replacement? So basically in a knee replacement, what we do is we resurface the ends of the bones. Now in the knee, we have 3 bones. We have a kneecap, we have a thigh bone, and we have a shin bone. The kneecap is the patella, the thigh bone is the femur, and the shin bone is the tibia. And so we resurface the ends of those bones, and we resurface them with metal and plastic components. So as you can see on this slide, the femoral component is in the upper left-hand side, and what we do is we make these specialized cuts. At Lakeland, we're very lucky to use computer navigation, and I'll talk to you about that, so we can make these cuts with extreme precision. Then we replace the tibial component, which you can see on the right, and we'll go into great detail about how we do that. Lakeland, as I said, we're very blessed to have computer-assisted surgery. And basically what computer-assisted surgery does is it helps us improve the alignment of the components that we put in total joints, and it allows us to use more than just our experience and some guides that can be or cannot be very accurate. I would consider it the GPS and the OR. We're all familiar with GPS in driving, and this allows us to use computer software to really very carefully place the components. So instead of having a satellite, we have a navigation camera. Instead of the pop-up display on your dashboard, we have smart instruments, and those two communicate with one another. And we look at a computer screen when we're doing surgery to ensure that we give our patients the most precise alignment that we can possibly give. And this is an example of the displays that we look at. This allows us very specifically to know how much bone we're removing and in what alignment we are orienting our components. And we're able to analyze this through the entire surgical procedure. And when we look at a replaced x-ray, this is what it should look like. If you look at the left slide, this is an x-ray looking straight at the knee. You can see how everything is nice and straight. And on the right side, we see a sideways view of the knee, what we describe as a lateral view. So who's a candidate for joint replacement, which we call arthroplasty? I think there are basically 4 basic components that you have to meet to be a candidate for arthroplasty. Number 1, you have to have x-ray evidence of arthritis. Secondly, you have to have at least tried non-operative treatment. Those would include injections, activity modification, medications, etc. The pain has to be affecting the quality of your life. I very often tell patients, we don't operate on x-rays, we operate on people. And if you have awful looking x-rays, but you're not having pain, you're not a candidate for a knee replacement. And we also need to optimize the medical status. So there are some patients that frankly are too sick or have medical conditions that have not been optimized that are not at this time candidates for knee replacement. So when we talk about surgical optimization, I think there are several things that come right to top of mind. Number 1 is smoking. It is very clear in the literature that smoking increases infection and total joint replacement. And we are uncompromising in our practice, and most surgeons in the United States are uncompromising. You must quit smoking before you have a joint replacement. The second is weight, and we'll talk about that in terms of BMI, bone mass index. That's a calculation based on your height and your weight. And generally, we like the BMI to be anywhere less than 45. We try to tell people we'd like to get your BMI less than 40, but we certainly will not do elective joint replacement on patients that have a BMI over 45. Physical deconditioning, a lot of people come to us, they have terrible arthritis, they haven't been able to walk or exercise. So I think this is a good role for preoperative physical therapy. Diabetes is a big issue. Very clear that if you have uncontrolled diabetes, you're at higher risk of an infection. After a joint replacement, we try to get your hemoglobin A1C below 7.5. If you have COPD, we want that controlled. If you have alcohol issues, we need them controlled. And we're very clear we want people to be off preoperative narcotics, if possible, before we do joint replacement, because the results in patients that are taking opioids before surgery just aren't as good as those that do not. So what should you expect if you have a joint replacement? Well, first of all, you should expect you're going to be in the hospital anywhere from 0 to 2 days. 0 would mean you would go home the day of surgery. That's very rare. Most patients come in the hospital, have their surgery, and go home the next day. Immediately, you're going to feel great. Between the blocks that we give you in surgery and the medication that we give you, you're going to feel pretty good, certainly in the first 24 hours. I always tell patients this is the honeymoon. Sadly, honeymoons don't last, but that first 24 hours is a good period. I always tell my patients that the first 6 weeks are the most challenging because we're going to be working on your range of motion and walking. And I would say this is the most uncomfortable time after a knee replacement. The first 3 months involve also building up your walking endurance. But on a very positive note, you should expect that you will see continued improvement for up to 12 to 18 months postoperatively. So things will be better at 3 months than 6 weeks, 6 months than at 3 months. and you have to have a long view. But the patient satisfaction with this operation is extremely high, but you have to have that long view. So how do people do? Well, we hope that people are very comfortable like these three ladies after their knee replacements. So about 93% of patients are satisfied at 5 years. There is a consistent reduction in your preoperative pain. There's a gradual process of improvement that, as I mentioned, can continue for up to 18 months. And the patient-reported outcomes are very high after total knee replacement. And if you look at how long do total joints last, we describe that as survivorship. And let me explain that. Survivorship refers to how many of these devices are still functioning at certain time intervals. So what we can see here, total knees, 97% of them are lasting at 20 years. Total hips, 85, and actually that's just been upped to about 91. And total shoulders, about 88%. So what you can see is you should not expect that you will need another operation after you have a total knee replacement. We expect this will last the rest of your life. Now, a little word about partial knee replacements. People always ask about this. Partial knee replacement means that instead of replacing or resurfacing all three of the surfaces of the knee, we just resurface one portion of the knee. A lot of interest in this over the last 10 years, done through a minimal incision. And if you look at this diagram, you can see on the left a total knee, on the right is a unicompartmental or a partial knee replacement. So it gives you an idea of what the difference is between the two. Now, very specifically, unicompartmental arthroplasty is indicated for a small percentage of the arthritic knee population. First of all, you have to have a minimal deformity. You have to have arthritis that's limited to only one compartment of the knee. So in the slide that you're looking at on the left, you can see that there's only narrowing on one side of the knee. If you have arthritis in any other area, you are not a candidate for a partial knee replacement. This is really best suited for an older, thin, and less active patient. These are less durable than total knee replacements. And in studies that have been done, it's very likely that you will require a revision of a partial knee replacement if you get it at an age under 65. So that's what I have to say about knee replacements. Today I've tried to talk to you about what is knee arthritis, what are the non-operative treatments for knee arthritis, who are candidates for total knee replacements, how do we do them, and what is the benefit of having computer navigation to have your total knee replacement done. At this time, I'm very happy to entertain any and all questions that you might have, and I hope I've been thorough in answering your questions.